I'm Mark Hennick. This is So-Called Normal. Hey folks, welcome to So-Called Normal. I'm Mark Hennick. Today on the show we have Dr. Catherine Zahn. Catherine is the CEO of the Centre for Addiction and Mental Health, CAMH, in Toronto, which is one of the largest, if not the largest maybe, psychiatric facilities in North America. We had a really interesting conversation. I've been wanting to talk to Catherine for a long time because while I've worked in the community mental health sector for the Canadian Mental Health Association for ages, we worked with people in hospital all the time. So I've always been struck by this and have experienced myself this duality of sorts between recovery in the community, recovery in real life, and all of the complications of that, versus the treatment that you get while you're in hospital. I was an inpatient on psychiatric wards at least 7 times, so I got to see that pretty intimately, and then having worked with many patients as well at CAMH. So I think we had a really interesting conversation about that, about where recovery happens, about the role of the psychiatric hospital in recovery, and we do get into NCR, not criminally responsible. CAMH has had a number of people that have made the media who have been found not criminally responsible, who have been released on pass, as is part of the system, a system that generally works, and who have absconded, who haven't come back or were found later, who tried to abscond. So we had a really interesting, I think, conversation about that and the implications that will have potentially on people's care in the future. So listen to our talk. She was a really interesting, compassionate, great person, and I really enjoyed my conversation with Catherine Zahn. So here it is on So-Called Normal. So, Catherine, thank you for coming in. As I ask everybody, especially I think people who are prominent, and you are prominent in the city of Toronto as the CEO of the largest psychiatric hospital, Centre for Addiction and Mental Health in Canada, for sure, I would assume, but likely one of the largest in the world. We'll get to that, but first, tell me about yourself.
Where would you like me to start?
Well, why do you do what you do? What's your interest in mental health? You're a neurologist by training?
I'm a neurologist by training, and I've actually worked in healthcare since I was a teenager.
Really?
My first job was as a nurse's aide in my local small-town community hospital.
Okay. In Ontario?
In small-town north central Ontario.
Okay.
Sorry, in small-town north central Ohio.
Ohio. Okay.
Ohio,
You've been in Ontario for so long that it's programmed.
I've been in Ontario for so long it's programmed. So I actually never left healthcare.
Interesting.
And why that is, I'm not 100% sure. I'm committed to taking care of things, taking care of people. I'm the oldest of 6 children, and it's kind of built into my brain to take care of business.
I tell people sometimes too, because I've only ever really done mental health, and that's, I guess, interesting enough, but it's also because I don't know how to do anything else. I have no other transferable skills. So once you find what you're passionate about, why not double down on it, right?
Exactly. So part of the story of what I'm doing now is related to the fact that I'm originally from Ohio.
Yeah.
My husband and I came to Canada shortly after we were married many, many, many years ago.
Okay.
And we came because he had a scholarship, and we meant to stay for just the 1 year. And a number of fortunate circumstances ensued, and we ended up staying. And we really liked coming to what was then a modest-sized city, but to us, coming from small-town America, it was quite big. We liked that idea of being anonymous and being able to reinvent ourselves. And we were both studying at the time.
And did you come here and practice as a neurologist, or did that come later?
That came much later.
Much later. Okay.
I finished university and then went to medical school here.
Yeah.
And we felt just fine, thank you very much, in Toronto until we had children.
Right.
And then we felt a significant loss of family. As I mentioned, I'm from a very big family, and I missed the idea of having my mother or my sisters here to support us.
How big is your family?
I have 5 brothers and sisters.
5 brothers and sisters. Yeah. Okay, so my mother was one of 17. So when people say big, and my father was one of 15. So 30 plus aunts and uncles. So when I hear people say big family, I'm always very interested in what they mean by big family.
Yeah. That's significantly more. Although I do have, I'm from a first cousinship of nearly 40.
40.
So it's there are a lot of people who I loved and who loved me.
And are they all still mostly in the Ohio area or spread out everywhere?
I would say
now?
Most are, but certainly there's a big spread, as there are with my siblings. Yeah. But at the time then I was a practicing neurologist, and it occurred to me that I might not be comfortable practicing medicine in the United States, but I did have an idea. I thought that if I had experience in a healthcare system that has a national healthcare system and a credential, that perhaps I could work for government or do something that would be valuable and appealing in the United States. And so I did a master's in health administration.
Okay.
And when you do something like that, you signal to the people around you a certain interest and a desire to do something different or more expansive. And I began to get requests to take on leadership positions, which started small and then became larger. And obviously, I stayed.
So how long have you been in Canada now?
Since the early 70s.
Early 70s, okay.
Most of my life has been has been in Canada.
But do you still remember, especially, you had exposure to healthcare in the United States. You said you didn't really want to practice healthcare there. So do you still remember the transition period, I guess, of getting used to a Canadian-style healthcare system? I mean, we're not fully single-payer, universal healthcare of other places, but it's still very different than the United States, right?
Well, it's a little bit of a tricky question to answer because as a child, again, in a small town, we had a family doctor who was very much Marcus Welby-like.
What does that mean?
He made house calls.
Oh, okay.
He was a prominent citizen in this small town, very highly regarded, very kind, very available. Everything from taking care of. He was a surgeon from doing surgery to delivering babies to don't laugh, but piercing my ears.
He pierced your ears? You couldn't go to Walgreens then?
No. And I paid. I remember paying him $5, which was a lot of money at the time.
Well, so it sounds like he had a big impact on you.
He did. He would have been my only role model for medicine. Right. So that's quite different than the situation then in the I guess it would have been in the 80s when we were imagining that we needed to go back to the U.S. Where I have friends and family who do practice medicine in the U.S. The issue with multiple payers, the restrictions, the concerns about how you practice and what restraints are put on you just seemed extremely burdensome and against my personal philosophy that healthcare is right, not a commodity to be bought and sold.
Right. And that's still, I think, maybe even more so now than a controversial stance, that healthcare is a right. So where do you see that, or how have you seen that evolve in Canada from the 70s until now?
I think only in a positive direction, in my opinion, that idea, especially.
So you're glad you stayed here then?
I'm very glad. I'm a positive position from the Canadian perspective. Yeah. I think it's more difficult now than previously to practice medicine in the U.S. As I mentioned, I have friends and family who are very, very burdened by the multiple insurers, the burden of documentation that seems irrelevant at times. So there are many reasons why I'm happy to be practicing here.
Well, I think it's a Canadian pastime in some ways to complain about waiting in the emergency room or something like that, or complaining about our healthcare system. Yes. But but it might be one of those you get used to it and you don't realize how good we have it here in Canada.
It's not without faults,
Sure.
and I do think that we have opportunities to improve. And I think those of us who work in the system and those of us who have a voice or have a leadership position are anxious to participate in positive change.
Yeah. Yeah. Now, where did your interest in mental health come along? You know, now being the head of a large mental health facility, the connection for people within the mental health system between neurology and mental health is pretty clear, but I'm not sure it's as clear to everybody. So where did that come up for you?
So as you mentioned, I'm a neurologist by trade, and my specialty actually was epilepsy.
Okay.
So I'm very familiar with people whose illness can produce changes in the way intermittently that they think or they behave that can be frightening to the general public, and my patients also were the subject of stigma or prejudice and discrimination against them because of their illness. I'm
Patients with epilepsy.
Yes, very deeply attuned to that. The practice of neurology includes many conditions like that change your thinking and your behavior. Those are always and remain mysterious and perhaps a little bit frightening to the general public. And for a long time, it has been my hope to dispel those fears and to help the people that have been my individual patients, but also the patients of the people that I've been able to support to advance that cause. So not a very big leap to move into mental health, but intervening or there's a interval in between when I was practicing neurologist and then I took on leadership positions. My previous job was at the University Health Network, where I held a series of leadership positions as head of the Division of Neurology, then the Neuroscience Program, and my last position there was as the Executive Vice President in charge of all of the clinical programs. So I became more general in my approach to healthcare, and when the opportunity to look at CAMH, the CEO position, came up, it was very intriguing. And the person who approached me was Paul Beeston, who was then the board chair at CAMH, and I remember questioning him as to why I would leave this gigantic job I have to a position that on the surface of it, by common metrics of the number of patients, the number of staff, the expense budget was smaller. He pointed out to me that the position at CAMH was not just running a hospital; it was an opportunity at an inflection point in the mental health movement to be part of the movement and to lead an organization that could carry that movement forward on their shoulders.
And how long have you been CEO of CAMH now?
I'm coming up to my 10th anniversary.
Oh, congratulations.
December 1st.
Congratulations. When you mentioned your work in epilepsy, I was a bit surprised to hear you talk about the stigma of it. Now, I don't have a lot of personal work in that area. My mother had epilepsy. Excuse me, she died of epilepsy, actually, of SUDEP. But I was not very aware of the stigma that existed there. Is there still stigma as you see it in epilepsy, or was there a successful effort to reduce that stigma such to the degree that I don't really know that much about it?
You know what, I'm a little removed from that right now, but I think that the simple answer is yes, because you will see fundraising events, you'll see Purple Ribbon events that are bringing to the forefront the nature of the condition, and I think it's the case that when we have more information about what the biological causes are, what the actual impact of the illness is on day-to-day living, and its intervals. I mean, there's a spectrum. Some people have easy to control and manage seizure disorders. Others have much more difficult that are associated with other problems. So there is that spectrum. But once we gain an understanding of these causes, and approaches to them, there's a lifting off of this darkness and shadow surrounding it. So I do think that there's an evolution, not only for epilepsy, excuse me, but also for other neurologic conditions.
Well, and this is exactly why I was asking the question, because is that a roadmap of sorts for what we're trying to do? And I think in some degree, to a large degree, have successfully started to do in mental health. And maybe you've seen it over the last 10 years as well. Has that stigma started to come down when we educate people more about the neurological basis of mental illness?
Yeah, yes and no. The starting point for me is that there have been two significant changes, a change in assumptions and a change in facts. So the change in assumption is that people with mental illness can recover.
Right.
So we've gone from the idea of resignation to recovery.
Right. That you don't just have to, it's not a death sentence. You don't have to necessarily live with this for the rest of your life. Or even if you do, you don't necessarily have to suffer with it for the rest of your life.
Mm-hmm. And then the corollary to that is the change in fact is that although our knowledge is imperfect, we have a much greater understanding of the complex interplay between our biology and our environment that is related to the origins of mental illness and the perpetuation of mental illness. So that leads to the idea that there can be interventions that can be effective, and that has moved us from the idea of institutionalization to reintegration into society.
And this really seems to reflect, I think, one of the most significant movements in our understanding of mental health now, that one of the biggest trends in the 90s and through the 2000s was this idea of the chemical imbalance, that we just need to rebalance the chemicals in your brain, and then you won't have depression anymore, or schizophrenia, or bipolar disorder, or whatever. It turns out there wasn't a lot of evidence for that to begin with, that it was in part associated with pharmaceutical marketing. But now it seems that we've moved on to this epigenetic approach, that this interface between, yes, maybe you have a gene that predisposes you to a mental illness, but whether or not it gets turned on, and there are a lot of other factors associated with whether or not you'll actually experience that illness. Because I think that there is some, I hear this from people on the ground all the time, some stigma associated with the idea that your brain is broken and therefore you need to go to a hospital or see a doctor to fix your broken brain. It's not always that. It's rarely that simple, right?
It's not simple, and certainly chemicals or neurotransmitters are important, but so is neural connectivity. Right. How one part of the brain talks to another part, how those neuroplasticity, how those connections become formed, become dysfunctional, become undone and redone through various types of therapy. And then the other layer I would put on this is that it's the case with many other complex chronic conditions that there is an interesting interplay between environment and in biology. Mm-hmm. So we know how important, for example, early childhood trauma, deprivation of any sort is. We know that people in lower socioeconomic groups are much more vulnerable, not only to mental illness but also to diabetes, to cancer.
Sure.
So it is very, very complicated. With respect to the idea of stigma, or the representation of mental illness being negative, I think that has changed somewhat, but not enough.
Right.
And I think that it's primarily true for people, for example, that have depression, but not so much for people whose illnesses produce psychosis.
I've noticed this too, that it's very popular now, especially with celebrity participation, to talk about seeing a therapist, for example, or taking even antidepressants. But we're still very afraid of people who have schizophrenia or experience psychosis in many ways.
And I'll go back to the earlier comment that I made, which was that individuals, because we don't know enough about the brain yet, individuals who have any condition that changes the way we think or behave remain confusing and fearful to the general public, and they're subject to prejudice and discrimination. The approach that I advocate for combating prejudice is the common one that has been tried and true, I believe, is education and familiarity.
Right.
If the more we know about these conditions, the more that we see people not only in their extremely ill phase, but when they've recovered, the more that we can combat that prejudice.
And there's a researcher out at Queen's University, you probably know, Dr. Heather Stewart, talks a lot about the idea of contact-based education as well, that sometimes our knowledge, we can have all the knowledge that we want, but it doesn't always translate to behavior change. People know things that are bad for them and do them anyway all the time, and vice versa, right? So then how do we actually make that jump? Great, we're educating people, we're making people aware. This idea of actually, okay, well, meet this person who has psychosis, and look, they're not killing you. It can be one of the most powerful ways to break down that ridiculous stigma that people with psychosis are violent by their nature. You know, we hear this all the time, despite the fact that it's not supported by the data. So then how do we do that more effectively? How do we reintegrate more effectively and show people that, look, these stigmas, these things that you believe about mental illnesses are not correct?
Well, there are a number of programs that are in place to bring that level of familiarity to the general public. We're particularly proud of one at CAMH where our trainees, our residents, our physician trainees are in a program where they actually interact with patients, and the patients behave as teachers. And it's so important for us as physicians, as nurses, as social workers, caregivers, to see the entire spectrum of an illness and to see that person who has recovered, see the real them that isn't the representation of their illness.
Well, very often healthcare providers, I mean, people don't typically come to see you when they're doing great, when they're doing super well.
That's right.
They come to see you when they're struggling.
That's right.
Now, we've often heard that, though, people who are struggling, one of the areas where they experience the most stigma or where they feel the most objectified is within the healthcare system.
Yes.
Right? This has been shown in survey after survey. So how do you address that? It sounds like one of these initiatives is exposing your professionals to people who are dealing with it.
And there's so much work to be done, and the visual, I think you can imagine someone who is acting in a way that's frightening to those around them. There are a number of reasons that you have that behavior.
Sure, behavior is information,
and
right.
we don't necessarily step back and respond in the most human and humane way. I have an anecdote from my early years as an intern in the emergency department.
I'd love to hear it. Yeah.
I remember a patient came in very combative, and you could not communicate with her. And I was very, very fresh as an intern, and one of the senior nurses was with me. And I said, "Well, we need to take some blood. We need to do this, and we need to do that." And the nurse said, "I know this patient. She's diabetic, and she's hypoglycemic. Let me give her some glucose." And I started to argue and say, "Well, that will ruin the blood work." And she goes, "Catherine, let me give her the glucose, and I will take the blood afterwards if I'm wrong." And there are a whole bunch of things to say about that hierarchy that she had to say, "Let me."
Yeah. Despite the fact that she knew the patient better. Yeah.
And she knew exactly what to do, and she treated the patient, who then woke up and said, "Oh my God, I don't know what happened to me." And she was perfectly fine. So it's learning, right? It's having that type of experience, having coaches next to you, people who are experienced and adept, and have that extra thing, not just the rules, right? I was going by the rules. Okay, you quick examine the patient, you do the blood work, you do whatever tests you need, and then you make a diagnosis, and then you treat. And she had the additional texture of this patient. She had the pattern recognition that she was able to respond in 1/10 of the time I was able to.
I previously had Dr. Brian Goldman on the show from CBC's White Coat Black Art, and he's very well known. He did a TED Talk. He's written books about it. The idea of culture in medicine, and you mentioned the hierarchy as well. The practice sometimes of not being able to admit when you don't know something, or you might even be wrong for legal reasons, for professional credibility reasons, all kinds of reasons. Have you experienced that yourself as a physician and now on the executive end of things? And how do you actually break that down, that culture which says that it's not okay if you don't know something to ask for help?
Well, the first thing I do is I try to role model it.
Sure.
And I think that this is sometimes referred to as the hidden curriculum in medical school. You have to uncover it. You have to make it explicit and have those conversations. I think that hidden curriculum is part of the angst of healthcare providers today. There's an evolution in the status of healthcare, the status of physicians in society that demands that we address that culture.
Yeah. Now, what would you tell a new doctor or somebody just getting into medicine about that culture? How would you tell them? What would be your advice for how they can deal with it themselves coming into it?
I would talk to them about their values, their core values, and encourage them to understand humility as being an important value to hold dear as a new physician, and to carry that through your entire career.
Right.
To understand that the people for whom you provide care are valuable human beings with rights, with human rights and civil rights and healthcare rights that deserve your respect.
I think it's in part a workplace mental health issue. It's a way of being more efficient to categorize people, right? And especially people who use the healthcare system a lot. They tend to experience more stigma than just about anybody else. I experienced that when I was a teenager and became the so-called frequent flyer in and out of, through the revolving door so many times that by one of my last discharges, they wrote in the notes, we're just going to leave Mark's file open because he's probably going to be back. They didn't even, so that tells me, though, and the reason why I use that example is that people who the more help they need, it seems like the less help they get, because others just start to categorize and to say, no, they're just here to abuse the system or whatever it might be. Maybe the issue is that their needs aren't being met the way that they need. So that thinking. To combat that thinking is really the origin of people or person or patient-centered care. What is that need? Step back and try to wipe away your preconceived notions. Well, and that's also good science too, right?
It is. It is, but there's something a little bit more specific about it. When I finished my residency, I have very, very good colleague and close friend, and I remember us talking about this and thinking of what our antidote would be. And he said, you should pledge to yourself that idea that every time you are faced with a human being who needs your help, you should try to find out one special thing about them.
Interesting.
That's not about the situation here.
Yeah.
Again, that's served me very, very well. I try to pass that on to in the olden days when I was teaching and responsible for trainees to help them humanize and continue to humanize themselves and the people that they're serving.
That seems to be a very prevalent theme in the evolution of CAMH as an institution as well. Can you talk to us a little bit about the history of a building that was at once called, was it the Toronto Lunatic Asylum or something to that effect, as many mental health facilities were?
I have a map on my wall in my office that I keep there to remind me, and it's from 1910, which is about 50, 60 years after the original building was built, and it's labeled the Provincial Lunatic Asylum.
Provincial Lunatic Asylum,
Provincial Lunatic Asylum, and it's by 1910 there was a significant residential area around the asylum, probably in response to the industrial lands below the railroad tracks, and yet there was a wall around the asylum. And when you look at the map, I imagine it. I'm a science fiction fan. I imagine it as some sort of a force field,
right?
That for many, many years kept things at bay, kept a wrap on or a constriction on the patients.
Right. And I had heard, I don't know if this is true or not, maybe you can tell me, if that wall was built by patients?
That wall was built by patients, yeah.
Wow.
And there's lots of discussion surrounding that, whether they were coerced,
sure,
or whether this was in essence forced labor.
Right. Well, that they built the walls that confined them.
That confined them. That's
Wow.
what's this. There's a horrifying irony around that.
Yeah.
It was also during a period of time when ideas similar to what we would think of as occupational therapy were extant.
Mm-hmm.
It's hard to be black and white about
sure.
that.
But the wall is still there.
Problem.
You've kept parts of it in the redevelopment.
Yes, the southeast and west walls are largely intact, and they will be. They will be maintained as I think an important reminder of
That's
the origins of
reminder.
the institution, the ability to cause reflection on what's gone before and what the future represents.
Mm-hmm.
So that facility, which was built in the 1850s, was one of the 4 organizations that in the late 1990s, as a mandate of the Restructuring Commission, were brought together to form CAMH.
Right.
So there was the then Queen Street Mental Health Center, the Clark Institute, which was part of the University Hospital System, the Addiction Research Foundation, which was a agency of government, and then the Donwood facility, which was a rehabilitation facility for alcohol.
Mm-hmm. Mm-hmm.
And so CAMH is 22 years old in its current form.
Yeah.
And that bringing together, I think, coincided with a well-developed recovery ideology surrounding mental health,
with the involvement of patients themselves and through the Empowerment Council, I believe. Right?
Yes, at the very beginning, the Empowerment Council and Family Council were part of the original behaviors of the merger, and those have been really, really valuable structures in the organization. So what's happened, I think, is it's exciting to compare it to the redevelopment that's going on. So as I've been at CAMH for 10 years, my predecessor, Dr. Paul Garfinkel, was responsible for creating the vision of the redevelopment, which we've been able to push forward, and we're undergoing construction right now of two large buildings that are really reflecting the changes within the organization of how we're organizing our programs, not by 19th century diagnosis or how you get into the hospital or your demographic, but how human beings see their needs and their care. So much more cohesive and coherent ways into the organization. It's not perfect, but driving towards improvement.
Well, and even the community around CAMH has really developed significantly. I mean, it used to be a threat to send people down to 999, right? But now it's actually quite a trendy community around that area.
Yeah, it's a very vibrant and exciting arts and design community that have been wonderful to work with as we're undergoing the redevelopment. So that redevelopment is a physical representation of all of the things that are changing and are happening within the world of mental health.
So all of this redevelopment happening on the outside, which is wonderful, though there have been redevelopment on the inside in terms of the architecture and the environmental design in which patients are getting care.
Yes, absolutely. All of the new buildings have been designed with that very thought in mind, with a significant amount of input from staff, patients, families, to understand what can be the best environment to support recovery, and as well to support safety of patients and staff. A simple example of that is the example of the 2 buildings that are currently under construction. One right now we refer to as the crisis and critical care building, and the other we refer to as complex care and recovery. So the physicality of the crisis and critical care, there's an emergency department, but also the care and therapy of people who are acutely ill takes place close to them.
Right.
They don't have to move around. So we have the therapy opportunities adjacent to where the inpatient beds are. Mm-hmm. In contrast, in complex care and recovery, we're trying to support people to prepare them to resume their life with their community, with their family, with their work, and so the therapeutic spaces are removed. So they have to go to another area or move about with increasing levels of freedom to become familiar with the ways that they'll return to society.
Sure. Well, and I think this is a really important point because not a lot of people realize that while recovery might be triggered by or even start in hospital, or the conditions for recovery might be started in hospital. I've never met anybody, and it wasn't the case for me, so maybe it's only anecdotal, but I've never met anybody who's actually recovered from their mental illness while being in hospital.
That's right.
Right? That it might kickstart it, but it doesn't happen there.
Well, it's a very, very small epoch in the life of an individual who lives with a mental disorder, and so you're absolutely right. Only a piece of it can happen in hospital. So we depend greatly on our partners in the community to interact with us, to increasingly develop better ways to communicate with one another, to ensure that we're there for each other, to really support the long-term recovery of our patients.
Now, CAMH has been in the news a lot lately for the idea of reintegrating people back into communities for day passes and for security reasons. There have been a number of people found not criminally responsible, which is finding a process that works for both public safety and rehabilitating people. However, we're still in a situation where there's a lot of stigma around mental illness and the misconception that people with mental illnesses are violent or even that they're likely to reoffend. So now people who have been on day passes as part of your regular programming have not come back, and it's happened several times. I understand that you're reviewing this and working to potentially make changes. Can you talk more about this whole situation?
Mm-hmm. So to start with, CAMH is as part of the mental health system. So we are part of a network of community, primary care, and inpatient services that support the recovery of all people with mental illness. We also have a forensic mental health service that is responsible for caring for people whose illness has caused them to become involved with the criminal justice system. Those people are found, most of them are in a category called not criminally responsible, which is determined by a judge, by potentially a jury. That's correct. That essentially means that their activity was carried out as part of their illness. So their activity was a product of their mental illness.
Sure. If you believe that you're being attacked by the devil or by aliens, you're going to react in a certain way. Yeah.
The test is: did you understand what you were doing? And that you were doing it, and did you understand that it was wrong? And if the answer to those two is yes, then you're referred to as not criminally responsible, and your disposition is governed by a provincial board in Ontario. Obviously, that's the Ontario Review Board that then sends an individual to a mental health facility such as CAMH for their care. And the process during their stay at CAMH is one of treatments, supports, restriction of liberty. That is again subject to some overarching rules and disposition by the Ontario Review Board, but it also includes the opportunity to have graded liberties, and those are subject to a number of tests, and by and large we do quite well in a large number of patients. Some some are deemed to have not obeyed the rules that are put around them. So, for example, they come back late, or they're brought back late. They don't come back because they don't want to come back. And we have processes surrounding that, and that then has consequences. That has consequences for them, but the forensic mental health system is actually quite successful in rehabilitating people, and I think you're probably familiar with the statistics that people who have been found to be not criminally responsible, who are under the care of a psychiatric facility, have a recidivism rate that's much lower than that of individuals who have committed offenses and are in the criminal justice system. So,
this is exactly the point that I raise to people too, is that if your interest is really in protecting the public, then having a punitive, just send these quote unquote nutcases off to jail, that old stigmatizing ancient view, it's actually riskier for the public. That's more likely to put the public in harm's way, because then they're not getting the help that they need. That NCR is the right approach, it seems.
Yes, and again, you're bringing up the point that there's a small proportion. There's a proportion of people with mental illness who commit violent acts, as there are of people who are not mentally ill. Right. The majority of violent acts are committed by people that do that. So it's again, it's a complex conversation to have, and it's not one that you can say is this is the rule here and this is the rule in another situation. But by and large, this is a system that in Ontario works very, very well. When I moved from a general hospital to a psychiatric hospital for my work, I brought with me a background and an intentionality surrounding quality improvement. And so to me, this is something we do constantly. We're constantly reviewing ourselves, our processes, our program structure and function, and finding ways to improve it. So for us internally, we've done reviews in the past of any serious incident that occurs, we review and on a small scale. If there appears to be a pattern, we do it on a bigger scale. In this instance, we want to have external validation of the work that we're doing. So we've announced that some weeks ago now that we would be undertaking an external review to look at our processes, and not just look at the processes themselves, but how well we're enacting them every single time. Right. And if there are issues in that process, sure, it should be addressed. But is there any concern? I would have concern as a mental health advocate that politics might interfere with clinical care of individuals. If somebody has been found not criminally responsible by a court of law, by a justice system, then they're not criminally responsible. Therefore, they're people who deserve care, and whatever structure that care has been mandated to be. But if somebody comes along without the clinical background, without the scientific background, and it determines that something else should happen, do you have any concerns that people's rights will be unfairly taken away, for example, in that kind of system because it's politically unpopular to see people who have been found NCR escaping from an institution? I think that's a risk, and I would say it's our job to carry out the legal processes that bind us, and to also continually balance the safety of the public against the rights of our patients. That's something that we do every single day. We'll continue to do that, and we'll continue to improve the processes through which we do that to build confidence in that. So to broaden out from the justice system then, but to stay with this idea of involuntary treatment, this is something that people, even within mental health advocates advocate for. I've talked to many parents, for example, who have suicidal kids and who want their kids to be kept in hospital until they're able to keep themselves safe. I had somebody on the show previously, just last week, I believe, who is a very strong opponent of involuntary admission in any respect. And this, I think, grew out of, this isn't new. It came out of the anti-psychiatry movement, the psychiatric survivor, consumer survivor movement. How do you balance that at CAMH between maintaining people's human rights while taking away some of those rights in some ways to leave the hospital or to leave the ward with
their own recovery with what's best for them, quote unquote. How do you balance that tension?
So, first of all, I just have to remind you, I'm not an expert.
No, and I should have actually said that up front.
I will tell you what I understand to be the good and right things to do, and the things that I would promote and support in
and I think
the
it's fair that you do head up an organization probably with more of those experts working at it than anywhere else.
Exactly, and they're incredibly generous.
Yes,
and they've been very patient and thoughtful in their education of me as the leader. But we have to be respectful of the Mental Health Act. Sometimes when we talk about rights, we talk about them as being absolute, and the truth is that they're always a balance. So in the situation that you're describing, we're talking about a balance between the right to refuse and the right to have care. And it's a clinical judgment that's made based on the patient's condition, the collateral information that's able to be accrued by the clinician, and there are appeals mechanisms in place that protect individuals. Once again, is it perfect? I can't say it's perfect, but we strive for that, for all of those balances: the right to care versus the right to refuse.
And if there might be something that's interfering with their right to care, if they're interfering with their own right to care, I guess, because of an altered state of mind, for example. That's an interesting way of thinking of it. I have actually never really thought of it quite that way before, but I think that's relevant in conversations, for example, around medical assistance in dying, and if mental illness as a sole factor should be eligible for that. That's something that I've opposed, but that other mental health advocates have advocated for, saying that people have the right to kill themselves if they want to. We're going to be releasing this on World Suicide Prevention Day. CAMH has taken, I think, a very measured stance on medical assistance in dying, but can you talk to me more about that issue?
Once again, I'm not an expert,
yes, of course.
I actually come from a place of religion and spirituality that persuades me to hold the position that it's not a correct thing to do, but. I certainly respect the perspectives of others, and am really pleased that we have experts that are able to participate in this conversation in a measured and in a meaningful way, and to try to get to the right to the right place. The large topic of suicide is also difficult to talk about and fraught with personal perspectives and beliefs. But what I worry about is when we talk about suicide prevention, we talk about it as the central thing to attack, and we forget to talk about the idea that suicide almost always, not always, but almost always, is carried out in the context of a mental illness.
Right. It's a symptom in many ways.
It's an endpoint, like let's say death from cancer, and so it usually occurs in the situation of depression or psychosis. So to me, the approach to suicide is one where we have to do three things. One, we have to educate ourselves better. To understand the predictors, the warning signs, the tools that can be to improve the tools that can predict who is at risk, and then educate individuals, not only providers but family members and the public of those risks. The second is access to care.
Yes.
So the statistics are that I don't even remember what the statistics are, but not by far anywhere near everybody who needs care has access to, for example, structured psychotherapy, or access to a specialist to monitor their medical care and their supports. So better access to care is the second one. So education, better access to care is the second one, and then third, at least a third of people, for example, that suffer from depression are not responsive to the usual medications and the usual treatment modalities. So we need research into better treatments that can prevent cure.
Yeah. Well, and I think it's also important to remind people too that about a third do respond to medication, about a third respond to psychotherapy.
Yeah.
The best practice is to incorporate, to wrap all kinds of services.
Yeah. So if to me the strategy is to implement those things towards preventing mental illness or mitigating the impact of mental illness and thus reducing the death.
Well, this is it. And people, I think people still don't often realize that suicide doesn't come out of nowhere, however surprising it might seem. And people, especially people who are close to people who have died by suicide, often tell me that they didn't see it coming. Mm-hmm. Well, that doesn't mean that there weren't signs. And it's hard to avoid, I think, the guilt of why didn't I see this coming. I tell people all the time, how could you? Nobody would want to think of somebody that they love that much not being around anymore. So they block it out, I think.
Or you don't see it, or you're self-upset.
I
mean, I've personally had that experience, and I this would be maybe 35 years ago. I still go over it in my mind. The last time my colleague called me and suggested that I come over and have dinner, and I remember being tired. I had a small child. I'm thinking I just can't do this. I can't do this, and putting it off. And then, why did I do that? How did I not know that she was calling for me? Right? Yeah. How did I not know that? I think that's so true, and I think that's common.
Have you come to peace with that?
Partially.
Yeah.
Partially, but it's still with me.
I think that's such a common experience for people. What would you tell others who have been in a similar kind of circumstance, who carry that kind of memory with them?
I have to think about that. I think you have to acknowledge it and acknowledge that you're not perfect, and you have conditions of your own life that sometimes prevent you from doing your best by everybody in the world.
Well, and it's also, I mean, first of all, they're not alone. I mean, hearing from you proves that. But also that it's not their fault. I wish sometimes it would be nice if we can control everything that everybody else does when we're not around, but that's just not the case, right?
Actually, yeah, you're saying it out loud that it is a little bit grandiose to imagine that you are responsible, but still it's hurtful, and you know this was a valuable human being that brought you value, and they're gone.
Yeah. Well, I think that your own vulnerability in sharing that story and so many other parts of your own experience and being open to the experiences of others is why CAMH has come so far as it has, and why it's been so open. And while, yes, there are things that still need to improve, we've seen dramatic changes. To go down and look at that wall that was built by patients to keep themselves in, to now some of the new structures, the new architecture, the new programs that are being offered. It's inspiring for me. Even now, having done this, having no other transferable skills, only ever done this for my entire, still short life so far, it's still inspiring for me to see the work happening in mental health now.
So the inspiring thing for me is to have been given this gift towards the end of my career to get to understand the people that we serve, and the fact that I mentioned earlier, to understand them as valuable human beings with rights, with human rights, with civil rights, with healthcare rights that we need to learn to respect better. And equally important, it's been so amazing to see our staff, the dedication that they hold to the work that we do, even though it's difficult, and they sometimes feel unappreciated by the system. But when I have, for example, a long service tea, I go around and I ask people why they stay, why they've stayed for 30 years, 20 years, whatever. And the number one thing that they say is because of the patients, because I'm dedicated to my individual patients. The second is, they say, because of their team, and the third is the cause.
So you've been there for almost 10 years now, Catherine. Why have you stayed?
The patients, the team, the cause.
Catherine Zahn, thank you so much for coming in and talking with me today.
Thank you.
All right, there we go. There's my conversation with Catherine Zahn. Dr. Catherine Zahn is the CEO of the Centre for Addiction and Mental Health in Toronto. I want to thank her for coming on the show, to CAMH for making it so easy, and for collaborating to get her to come in and speak about some really important issues. I'm interested in hearing what you thought about that, your perspectives on hospital treatment, your experiences. If you've had treatment in hospital, either yourself or for your friends and family, get in touch with me. Share the episode and let me know your thoughts on Twitter, Facebook, Instagram, LinkedIn, YouTube, wherever. I'm everywhere. You can find me at Mark Hennick most places. That's at MarkHenick. You can also head over to my website, markhennick.com. I would like to ask you a huge favor, as I do every single week, to head over to Apple Podcasts and subscribe to the show. If you scroll all the way to the bottom, you can leave us a rating as well, a star rating. 5 stars would be nice, or 4 if you thought it was okay. 1 star if you really need to be honest, but I don't want to encourage you to give me 1 star. So 5 stars, I love them. But whatever you think, I want your honest feedback. And leave us a comment, too, in the bottom. Give us your thoughts about the show so far and suggestions for future guests that we should have. I read them all. I love them. So please do that. You can also find us on Stitcher, Spotify. Where else are we? We're everywhere. We're on every platform. Google, Libsyn, everywhere else. So not hard to find, So-Called Normal. Listen to all of our past episodes. We've got lots of them up there, all really in-depth conversations. I want to thank the folks that we have who make this show possible. Adrian, Kimberly here at Entertainment One, Dave, our amazing editor who brings it all together, and thank you, of course, the listener, for your engagement with this, your support for the show. I really look forward to having these conversations every single week, every Monday. So I'll be back next Monday. Thanks, and I hope to see you then on So-Called Normal.